Hello, welcome back to Catch 2011, the endovascular treatment of cardiovascular disease. The last video talked about coronary artery disease, and now we're going to transition from that to other vessels, mainly carotids, the aorta, and then the aortic valve itself. And we're going to start with carotid disease. But first I want to introduce my colleagues, Dr. Stephen Voice of Advanced Cardiology Specialists, and Dr. Alessandro Smeraldi of Premier Surgical. Let me start with Dr. Smeraldi. Why do we treat carotid disease, and why might stenting be a reasonable alternative for those patients?
Carotid disease accounts for one of the leading causes of death in the United States and a significant amount of cost and morbidity to patients as a result of strokes. And the vast majority of strokes are caused by cerebrovascular disease or disease within the carotid arteries. Traditionally, an open operation whereby we remove the plaque is how we treat that disease. But now with the advances in technology, we're able to use stenting techniques to minimize the invasiveness of the procedure to the patients and still get the result that we need by minimizing their risk of stroke going forward in the future.
So tell us a little bit about the high standard that's been set by traditional carotid endarterectomy, and tell us what exactly is carotid stenting.
Carotid endarterectomy is a traditional operation whereby we remove the plaque in the carotid artery and remove the risk of embolization or debris going into the brain that would normally cause stroke. The operation has been around for many years and has been perfected to the point where the risk of stroke is about 1% and the risk of other complications is less than 5%. It's hard to top that. Carotid stenting is a procedure where we remotely place a stent, let's say from the groin artery all the way up into the neck artery, and trap the debris and prevent it from going into the brain. It's an equally effective technique, but it has some risks to it.
Let's turn to Dr. Voice. Has carotid stenting met its potential, and has it come to equal the efficacy of traditional carotid endarterectomy?
That's a very important and very interesting question. As far as carotid stenting and carotid endarterectomy, the studies have looked at both of these modalities more frequently than any other combination therapies ever previously done. Comparison studies looking at stenting versus open surgery endarterectomy have been done in over 10,000 patients at this point, so we have a huge database. And the answer is that things are very similar, and you have to pick your point of what is important in stenting versus endarterectomy. The studies would suggest that stenting is equivalent for risk of death, myocardial infarction, heart attacks, and strokes over a period of time. However, there may be some differences in the various risks of the various procedures in various groups.
So what's holding it back? Why isn't it the predominant procedure of choice for patients with carotid occlusive disease?
Well, some of the advantages of stenting over the typical surgical technique is that it's less invasive, and the risk of other problems such as myocardial infarction, heart attacks is less in those patients undergoing stenting than in those patients having the open surgery. However, the risk of stroke may be slightly higher. The problem is protecting the brain circulation from any plaque or material that may break off at the time of a procedure.
How has the technology evolved to help protect against stroke?
In the early years of carotid stenting, in fact, a lot of times stents were not even used. A simple angioplasty was performed whereby the artery was dilated in the hopes of achieving a better quality artery, and that turned out not to be effective. We then developed the use of stents to trap the debris so that debris wouldn't go into the brain. And ultimately, the final leg in the maturation of carotid stenting is using some sort of protection device whereby that debris that Dr. Voice was talking about doesn't go into the brain, but gets trapped in some sort of filter or net and can be retrieved at the end of the procedure and protects the brain.
Right, and since the overall theme of this conference is the endovascular treatment of cardiovascular disease, Steve, haven't we seen that similar evolution in technology, for example, treating disease saphenous vein grafts, and now we're going to see the same sort of thing for valve therapy in the future, the evolution of the technology?
Correct. The distal protection, in other words, trying to prevent debris from flowing downstream, whether it's in an artery in the heart, artery in the brain, in the kidneys, or when one places a valve in the heart to prevent the material from moving to other areas of the circulation, is clearly an area of active interest and investigation, whether it's filtered devices to trap the material as its blood flows through it, whether there are occlusive devices to stop blood flow and then suck out the debris are all in evolution at this point in time. And that will be the key events for these types of endovascular therapies moving forward in the future.
Right. And let's go back to the limited growth of carotid stenting so far. Haven't the payment issues had something to do with that? And Alessandro, what do you see coming down the pike that may cause a burgeoning in carotid stenting?
I think more so than any other procedure that we've developed in vascular surgery, carotid stenting has been highly scrutinized, as Dr. Voice said. And along with that have been the reimbursements, payments, and FDA approvals for when to use these devices. That has gradually emerged as an equivalence to carotid surgery. And we may see in the future that the indications may expand and we may be treating more patients with carotid stents than we are today, but that may still be a few years down the road.
So just like we saw an evolution in percutaneous coronary interventions, we see the evolution in the treatment of other vessels, and we will probably see the same evolution in valve therapies. What initially is indicated for high-risk patients gets expanded to a lower or moderate risk population, don't you think?
Exactly, and that's exactly what's happening in the carotid stenting world. As of May of this year, the FDA has approved carotid stenting for use in all patients with carotid disease, not just those highly symptomatic patients that would be poor surgical candidates.
So with carotid disease as sort of a background, as a paradigm for the treatment of other vessels outside the heart, we're going to move on to the aorta. And I'm going to ask Dr. Voice to describe what we've talked about up until now. Coronary disease and carotid disease have been mainly occlusive diseases where the vessels become narrowed. When we talk about treating the aorta, we're talking more about aneurysmal disease, which is an enlargement of the vessel. So Steve, why don't you tell us about risk factors and something about the epidemiology? Why do we treat this disease?
Well, blood vessel disease is blood vessel disease, simply put. And the risk factors that affect blood vessels in the neck or in the heart or in the abdomen or in the legs, the risk factors are similar. Some have weighed differently on the specific area of blood vessel we're talking about. But specifically, things that we look at are problems like having a history of high blood pressure, diabetes, high cholesterol levels, cigarette smoking, or a family history of blood vessel disease.
Aren't those all risk factors for coronary artery disease as well?
They all overlap, absolutely. Some are more so than others. For example, for the abdominal aortic aneurysm, smoking and a family history may be the predominant risk factors that we're looking at. What happens in the abdominal aorta, the big blood vessel in the belly is what we're talking about, is that in addition to plaque development, thickening of the walls and so on, there's a change that occurs that the blood vessel itself enlarges, and that's what an aneurysm is. It increases in size. Why that happens is a subject to some controversy, but there seems to be differences in how inflammation and certain molecules that are released in the bloodstream affect the blood vessel wall in the aorta. Things called proteases actually may break down some of the structure of the artery and allow it to expand in size.
Okay, well, now that you mention it, let's talk about the morbidity of an open abdominal aneurysm repair versus an endovascular repair. Can you tell us about that?
There's a big difference. Unlike the carotid stenting versus surgery debate, where there's very little difference in outcomes in terms of length of stay or morbidity, there's a bigger difference for aneurysms.
And that's because a carotid operation is a smaller operation, but you have to have your belly open to treat a AAA is a much bigger procedure, isn't it?
Very much so. Yeah. In order to fix an abdominal aortic aneurysm, it generally requires a large midline incision whereby the abdomen is opened and all the contents are moved out of the way to get to the artery, and the artery is essentially replaced.
And doesn't that clamping of the aorta put a tremendous burden on the heart, and many of these patients have coincident heart disease?
It certainly does. Just that the fact of clamping the artery alone puts a lot of strain on the heart, it puts stress on the kidneys, and it puts stress on the lower half of the body that then has to be resuscitated at the end of the procedure. The concept of stenting is to minimize all of that, and instead of making a large incision in the belly, we make small incisions in the groins, and we deploy a series of stents that can be assembled inside the body to essentially reline the entire artery and exclude the aneurysm without having to make a big operation.
Okay. It was still a pretty big operation, though, to put a big tube inside the aorta. And it doesn't come without any risk. But tell us about the short-term outcomes, particularly the risk of myocardial infarction for endovascular repair versus open repair.
There's a big difference. In terms of the mortality, you're looking at a 5% mortality with open surgery versus maybe 1 to 2% mortality with an endovascular operation. And you're looking at least a 5 to 10% risk of a major cardiac event with open surgery and a less than 5% risk of any kind of major cardiac events with an endovascular procedure.
Okay, so now here's a theme that keeps emerging when we talk about endovascular treatment of cardiovascular disease. lower upfront risk. How do we do long term? Is it as effective? Is it as durable?
It's as durable. Initially, the reoperation rates for endovascular procedures was about 10%, and that has gradually come down, mostly due to the advances in technology and science. We've gotten our stents to go through smaller tubes, and they've become better at staying where they're supposed to stay. But the long-term effects are still unclear. Because of the high underlying risk of coronary disease, patients are still not surviving 10 and 15 years out as any differently than they were with open surgery or with endovascular surgery.
Steve, what do you think is the driving determinant of the long-term outcome for endovascular treatment of aortic aneurysm?
Well, the issue is really the concomitant diseases, other diseases that are going on in the body. And just as we were talking earlier, that the risk factors are the same when one has blockages in an artery or an aneurysm in the belly, the risk of having blockages elsewhere is also very high. Blockages in the heart arteries is very common in this situation, so the risk really boils down to, at least in the long-term risk, boils down to how the heart and brain circulation goes. These people typically die after a successful surgery. They will die of heart disease down the road. In fact, when we look at assessing someone's long-term risk for heart problems over a period of time, the guidelines would say patients that have an abdominal aneurysm have a risk of another major cardiac event of about 20% within 10 years, which is similar to the event of a patient who's already had a previous heart attack. So having an aneurysm in your belly is similar risk as if someone who's had a heart attack in the past.
So it's interesting. CATCH is about convergence, and here we have a cardiologist, a vascular surgeon, and a cardiac surgeon all talking about this. And the emphasis with the Syntax trial, and we'll talk a little bit about valve trials in the future, is about having a heart team approach. These patients don't have disease in just one system. The disease is throughout their body, and we have to assess them overall. Another theme that we saw when we talked about coronary disease and carotid disease is that, and now aortic disease, is there's a need for continued imaging and perhaps subsequent interventions in the patients. Am I right about that?
That's been a big debate and controversy. Anybody who receives an endovascular aneurysm repair requires CAT scans on a yearly basis for the remainder of their lives. That's a lot of radiation, that's a lot of dye, that's a lot of stress to the body. That is something that we're trying to minimize, but that is one of the pitfalls of an endovascular procedure.
And Steve, you were going to make another point.
Yeah, I think it's similar in any aspect of cardiovascular disease. It's cardiac, it's vascular, it's all the blood vessel diseases, that when we do an intervention, be it a stent in the heart artery, be it a stent in the aorta or in the carotid, there's a lot of other blood vessel there that's not treated by that stent. And we need continued medical therapy and continued follow-up to try and minimize the risk of future stroke, heart attack, needing for other vascular procedures in the future.
Yeah, and speaking of other arteries in the body, we're going to continue to move up the aorta to the thoracic aorta, which can have aneurysmal disease, and the technology for stenting of that is rapidly evolving as well. It's not quite as clear-cut which patients should be treated because we don't have the same rich trove of data that we have for the abdominal aorta. At what point do you intervene, and what's the risk-benefit on that? A traditional open operation for the thoracic aorta carries even more risk, if you will, than the abdominal aorta, because there's the risk of not only stroke and MI, but the risk of paralysis when you clamp the aorta in that area. Do you have any comments about that?
Interestingly enough, the data with respect to spinal cord ischemia and paralysis has shown to be very similar between open surgery and endovascular approaches, with a slight preference to endovascular procedures, whereby we are actually seeing a little less incidence of spinal cord ischemia with the stents.
Let's talk a little bit about aortic stenosis or aortic valve disease. And traditionally, when this problem presented, patients had only one choice, which is an open heart operation. It requires cardiopulmonary bypass, the circulation of the blood through a heart-lung machine, and arresting the heart, stopping the heart, so you can open it up and cut out the diseased valve and sew in a new valve. Now, we've evolved recently to less invasive approaches, mainly smaller incisions, but it still requires stopping the heart and opening it up to treat the valve disease. Now we have transcatheter aortic valve insertion, or TAVI. Steve, where do we stand right now with TAVI, or transcatheter aortic valve insertion?
Well, I'm going to take a step back so that the listeners are aware of what we're talking about. The aortic valve is the main valve between the pumping chamber of the heart and the rest of the body. And the most common valvular procedure we see is replacement of that valve due to that valve narrowing down, and typically increases in frequency with age. The valve becomes stiff and calcified, it doesn't open, and the heart can't pump. Historically, surgery is the only method that we have. No medical treatment that we've used controlling blood pressure, controlling cholesterol, et cetera, has shown an improvement in outcomes versus no treatment. Surgery has been the gold standard. Now, just like all technologies, we're trying to get quicker, faster, less invasive types of treatment. And that's where the transvascular valve replacements come in. The TAVI is being done predominantly through the leg or through another incision in the chest to put a valve basically over a catheter into the aortic valve. The most recent trials have come out just recently, explained in the American Heart Association, American College of Cardiology meetings, looking at a trial called PARTNER, which I think we'll talk about here in more detail. Looked very exciting on really the first major trials in this TAVI technique.
So PARTNER trial had two limbs. One was for patients who were deemed inoperable, too old, too sick to undergo open heart surgery. So they were treated with medications alone versus transcatheter aortic valve replacement. They picked a high-risk group. There's a scoring system to determine the risk of death for these patients. And they had a remarkably high mortality rate in the medically treated group, 50% at 1 year. But there was a surprising improvement in survival for the TAVI patients, a full 20% less. That's an absolute reduction of 20%. So 30% mortality at 1 year in the transcatheter treated patients in a very high-risk population.
Right. They actually estimated in the patient population that could not undergo surgery or felt to be too sick for surgery that had TAVI, that they added an average of approximately 2 years onto their survival. So it was very exciting to see that.
And if you look at a quality-adjusted life year point of view, it's also cost-effective, even though this technology is quite expensive at this time.
Yes, it's expensive up front, but the cost per year of survival and cost for quality year of survival has recently been looked at and has been consistent with other types of treatment that we routinely do in the United States.
And the evolution of this technology has called attention to the fact that aortic stenosis may be undertreated, particularly in the elderly, because they're deemed too old or too sick to undergo any treatment. But now we're sort of scrutinizing them again. Are they candidates not only for the transcatheter, but how would they do with the surgical treatment of the disease? With TAVI, we see, again, an increased incidence of stroke and with vascular access complications. For example, the stroke rate in this PARTNER B cohort was about 5% at 30 days for the transcatheter and 1% in the medically treated people. And the vascular complication rate was 16% versus 1%. So back to Alessandro for a second on the evolution of the technology, the delivery systems, and the distal protection. What do you see happening?
I think that this is probably going to go the same way that carotid procedures and aortic procedures have gone. We've managed to tweak the technology so that we have ways of protecting the body from stroke, and we have ways of minimizing the size of the tubes that are used to deliver these devices so that we are less traumatic to the arteries as we pass them through the body. We've seen that both with carotid stenting and with aortic stenting, and I suspect that we may see that as valve interventions develop.
Now, as we're recording this, the PARTNER A cohort, the other group, the results are just becoming available. And we see that for patients who could have high-risk surgery versus transcatheter aortic valve insertion, the survival rates are similar, but the complications are different. For example, major bleeding was much higher in the surgical group, as you might expect, when patients have larger incisions made and get systemic anticoagulation for cardiopulmonary bypass. But again, the stroke and vascular complications are a little higher in the TAVI group. Steve, do you have any feel for how that's going to evolve?
Yeah, I think it's interesting. PARTNER A took high-risk patients that had an estimated risk of anywhere from 10 to 15% risk of a surgical procedure, but we're still felt to be able to have a surgical procedure, randomize them either to surgery or the transcatheter valve. The outcomes were like you discussed. There were some aspects of the transcatheter valve that had higher risk, stroke and
vascular access,
and certain problems with the surgical aspect, which was bleeding and the development of irregular heart rhythms after the procedure. However, the survival was the same. Problem that we look at is the survival is the same, and out to a year, still 25% of patients died at approximately 1 to 2 years out from the procedure. Right. So it's still a very high-risk group.
And again, they pre-selected an extremely high-risk group, so folks don't get the idea that aortic valve replacement carries a 25% one-year mortality. These are people who, had they not been operated on, might have been closer to the 50% mortality.
Oh, absolutely, probably a 50% mortality at a year or better.
Right. And then with regard to the long-term durability of this, we see a fairly high incidence of paravalvular leaks in the transcatheter group. And of course, this is something else that may be amenable to evolving technology. But the paravalvular leak seems to be related in some way to the mortality. They seem to be linked. So we're not sure yet about durability in that regard.
Correct. I mean, we're still working with early generations of these valves. This is really first/second generations of these transcatheter valves. So it's very early in the technology. And to see such a dramatic step for these high-risk patients being relatively equivalent to a surgical group is a major step. It's very exciting.
And with regard to those new technologies, the PARTNER 2 trial has already begun in Europe now with a more slender delivery system to overcome those vascular access problems and hopefully avoid the paravalvular leaks as well. So in summary, transcatheter aortic valve is available soon in the United States, perhaps FDA approved by the end of 2011, at about the time that we're having our CATCH symposium. And we can evaluate patients for that right here in Scranton. Do you agree?
Certainly it can be evaluated here. I think we need to consider those patients that may have been rejected for for valve replacement surgery or other interventions as being too old or too sick may be potential candidates for this therapy in the future, very near future.
Well, that's our discussion about carotids, aortas, and valves, and I want to thank our sponsors, and I want to thank WVIA Studio for helping us record this video. We look forward to seeing you again at next year's CATCH.